it's got two sections. The first section is, and you do have a hard copy of the slides, is talking a little bit about some of the things that we see in the media and how right or how wrong they are. And then the second half of the presentation is going to focus on one particular study, which is called the MacArthur Risk Assessment Study, that has a lot of, I think, valuable data that kind of drills down a little bit on some of the issues about what's related to violence for persons with mental illnesses. So that's kind of what the setup is. And you can tell me, I think I have 30 to 40 minutes worth of material. It's a presentation I haven't done before, so I'm guessing. But we got an hour time block to get you out roughly 12:30, 12:35 for lunch. And we'll see how it goes. So I think I have 30, 40 minutes worth of material, which will give us 20, 30 minutes for conversation. Okay. Let's see. One of the first things when we talk about this, and I'd like you to be, I hope, a little bit more discerning consumers of information at the end of this. And one of the things that you have to be really discerning about is people tend, in the media, legislators, the people in the community, tend to use the term violence and violent crime interchangeably. And sometimes when they're talking about violence, they talk about violent crime, and they don't understand what the difference is. Now you do. This is your business. Now you're coming at that business from a couple of different perspectives, but it's really important when people are talking about it, and you'll see when I go through some of the data, how it gets mixed up in the press and how the different meanings are. The study at the second half of this presentation that I'm going to do is focusing on violence and what is the prevalence, the type, and the relationship between certain key factors in violence in the community by persons who have been hospitalized for psychiatric treatment. And it's really important when you talk to people and discuss these issues, I think within your projects or within the public, or when you go into county appropriation committees and you're talking to people or you're talking to reporters, to make sure which of the two you're talking about. One of the numbers that you see, and there was every New York Times story that's been written since Newtown has had this number in it. And they say, what percentage of violence, sometimes they say violence, sometimes they say violent crime, is as a result of persons with serious mental disorder. The number that you see over and over and over again is 4%. That's the magic number. Sometimes it's 3, sometimes it's 5. And you see it when it's from, they're talking about persons violent or with violent crime. The number, and then what happens is, then you go from that number. This was a blog called Just 1 Minute. So they take the 4%, and then they make this statement. That means 96% of violent crimes, defined FBI, are committed by people without many mental health problems. Does that statement flow from this number, even if you take this number? Of course not. This is people with serious mental illness. Schizophrenia, acute depression, and bipolar are the 3 categories that are usually in there. And then are committed by people without mental health problems. Of course, there's lots of other people with anxiety disorders, substance abuse disorders, and all kinds of mental health problems. So it shows how careful you need to be with just accepting that number and then what people do with the number. Then the other thing, I want to go back to that number one more time. The number of 4% that says what percentage of violence is perpetrated by persons with serious mental illness comes from one study. It's a big study. It was done in the late 80s, called the Environmental Catchment Area Study. And Jeff Swanson wrote a seminal article in 1994 on what percentage of persons with mental illness reported violence, and then of all the violence that was out there, what percentage was by people. And he came up with 4%. That was one study, very rigorous, 10,000 people in the study. That's where that 4% comes from. I don't know, frankly, where the 4% of violent crime comes from. The citation you see over and over again is the National Comorbidity Study. And that study did a random sample of residents of the US and looked at how much, they asked them self-report, were you arrested for a couple of crime categories, were you ever arrested? And then they looked at what percentage of people had serious mental illness and had a violent crime, and then looked at all of the crime that occurred in the country and said, in those communities that they studied, and said what percentage were seriously mentally ill. 4%. One study, not a great methodology. Everybody uses a number. So I'm just saying, and then some of the people that have looked at the environmental catchment area data in the National Comorbidity Study, one for violence and one for violent crime, have suggested that that's an underestimate because it includes people without co-occurring disorder. And it may be closer to 8 to 12%. So, but nobody ever uses the 8 to 12%. And I'm not saying, I don't think it's the only resource, and I'm not sure they really measured violent crime particularly well, but as consumers of information, that's what's out there. And it's not a lot, but it's a figure that everybody uses and then uses to draw conclusions. Now, the flip side of this is the Basel Center for Mental Health Law, which is an advocacy organization for persons with primary behavioral health disorders. Shortly after the Sandy Hook shooting, they said, people with mental illness are no more violent than people without mental illness. That's wrong. And we'll drill down on some of those numbers. But persons with serious mental illness, I'll give you the kicker. People with serious mental illness and co-occurring substance use disorders have rates substantially higher than the general population. If you take people who simply have serious mental illness with no co-occurring, they're about the same. That's the punchline. I'll give you some numbers to go with that, but that's the punchline. And when advocacy organizations say this, that's wrong. And you need to understand that. And when people come at you to defend your programs and to say, shouldn't we be doing something with people with mental illness in terms of their access to guns, their level of supervision, you should not say, but they're no more likely to be violent than their neighbors. Well, to the extent that you look at some of the data that Dave DeMora presented, that the rates of co-occurring disorder among persons with mental illness are much higher than the general population. So you just need to be a little bit sophisticated about that and be careful not to buy into that because it's not right. Now I'm going to go to the study that we did. People between the ages of 18 and 40, men and women, all diagnoses. They were admitted to state psychiatric centers in Pittsburgh, Worcester, Massachusetts, and Kansas City, and approximately 1,000. They were hospitalized for an average of 9 days. These are not long-term state psychiatric patients. Hardly anybody's long-term hospitalized unless they're forensic cases. So they were typical people in terms of they were diagnosed with serious mental illness. They were on average 9 days, and they were released to the community. We interviewed them every 10 weeks in the community. We had research assistants that went out and we found them and we compensated them, and we got a whole bunch of information, one of which was self-reported violence. Say, oh, pretty weak measure. But we also interviewed a collateral for every one of them, and we had official agency arrest records. So we actually had triangulated the reports of violence. So I think it's pretty accurate. Not perfect, but it's pretty accurate, and it's better than what most people can do. We had the MacArthur, John D. and Catherine T. MacArthur Foundation funded this, and it was funded at a much higher level than a lot of research is. So how do we define? Let's see. The question is, you can't quite see it at the top here. In the past 2 months, yeah, okay, have you? And this is what we asked them. Did they do this? And then we asked if they said yes, where did it happen, and who was involved? So throw something, push, slap, knife, choke, hit anyone, you can read that. Those are the questions that were asked every 10 weeks. This is how we define violence for the purpose of this study. Did they use a weapon? Did they threaten? Did they actually have a weapon in the hand? So they said, well, you know, if you don't get out of my face, I'm going into the bedroom, I'm going to get the gun out of the drawer. That didn't count as violence unless the weapon was actually in their hand. If there was any sexual assault and any battering resulting in physical injury. And it's it's not arbitrary, but it's kind of hard when you're measuring this. What are you going to count? Every time someone kicks someone or slaps someone? So it had to, if it was a bruise, a cut, if there was an injury involved. So some of it was less severe than others. But as I talk, and this is, you know, the physical injury, spanking, violence or self-defense, in any time, if they were re-hospitalized or rearrested and incarcerated during the follow-up, this is all community, it wasn't counted. This is all community behavior. And what I'm going to do in the next couple of slides is say, well, what do we find? How many incidents of violent behavior? Where did they happen? Who was the victim? Well, let's talk about that for a second before I go to it. When you do studies of violence and you're interviewing people, if you say, okay, well, tell me exactly what happened, the person who is initially the perpetrator oftentimes ends up as the victim, and vice versa. So it's very difficult. It's not clean. It sounds clean. Well, who's the perpetrator? Who's the victim? Well, it changes during the course of the interaction and the violence sometimes. This is what, during the year, 1 year follow-up, we did them 5 times every 10 weeks, and there were a total of, in terms of people we had data, 951 people. 689 of them had no violent incidents, but in one of the 3, self-report, collateral, or official agency arrest records. And then you can see 145 had 1. No. So there was a total of 27, just over a quarter, of all of the people we interviewed in a year had 1 or more violent incidents. And the total number of violent incidents was 608. So when on the subsequent slides where we talk about what were the factors that were related to those violent incidents, that's the number that we're working with. And one of the things, in terms of looking at this, and you know, those of you that are doing clinical work on your projects, it's not that hard to have 1 of anything. So when you look at this, 145 people had 1 in a year. I mean, the people in this room, 10, 15, 20%, maybe by our standard, might have had a violent happening where you kicked someone because you were pissed, they fell down, scraped their knee, you would have counted as a violent incident. But in terms of repetitive violence, you can see this is a fair number. But again, that's the prevalence. And there wasn't anything to say, was that a lot? Was it a little? Was it more than? Less than? There's really nothing to compare it with. It is what it is. Okay. What was the type of violence? The 608 incidents. 12% were throwing, pushing, grabbing, throwing an object, kicking, hitting, beating up. Sexual assaults were relatively infrequent, and weapon threats. One of the things we just went back after some reporters called after Newtown, and to look at how many actually involved a gun, and it's about 11% of all of these incidents actually involved a gun. And it was a threat. We didn't have anyone who was killed with a weapon, with a gun. And weapon, again, if someone got angry and picked up the lamp that was on the table, and that was considered a weapon. It wasn't anything that was used to attack. So again, is that a lot or a little? But it gives you some insight, drills down a little bit in terms of what we're talking about. And I think this is terribly important. Who was the target of these 608? 14% were strangers. 86% are family members, friends, or acquaintances. When violent incidents occur with persons with serious mental illness, they almost always know the person. It's not stranger violence. And again, that's something people don't talk much about, except if you're a member of the National Alliance of Mentally Ill and you have a family member, and this is among their big issues in terms of we need assistance with our family member who at times will get violent with us. But from a public policy standpoint, the debates that we see post tragic events, that the people that you live with are most apt to be the target of the violence. The next set of slides, and there's only a few, this is not a long presentation. The next set of slides looks at what were some of the key factors that were related to violent events, those 608 events by the 262 people. What were the factors related to them? And the ones that I picked out here, I mean, we had 64 factors and 31 actually into the multivariate prediction equation and so forth. But I want to just take some of the bivariate, some of the single factors that clinically and practically, again, the title here was some practical information. What might you be able to use? So the first I want to look at is diagnoses. And what we see here is, let me step over here. So the top row is the first 20 weeks that people were out, and this is in the first year. And what you see is the same pattern, whether we talk about the first 20 weeks that people were out, we took the first 2 time periods, figuring that that was the closest to the intervention, the treatment that they received in the hospital. And what you see is, and then across the top we've got 3 columns, whether there was major mental disorder, no substance abuse, major mental disorder with substance abuse, and other mental disorder. That's almost all personality disorders, which again, the clinicians house know one of the easiest ways to get a personality disorder or antisocial personality is you have a long rap sheet and you're violent. So it's almost tautological. So you see, without major mental illness, no substance abuse, 10%, twice as high. Same pattern over 1 year, almost twice as high with co-occurring substance abuse, and again, this other category. The next slide is just displays basically the same data in a pretty graph, and it just shows that no substance abuse stays relatively low and is always low, and that's the middle and that's the high. Now, the other thing, and you may have fun with this, the clinicians, this breaks down the serious mental illness into depression, schizophrenia, bipolar, other psychotic, and alcohol and drug as a primary diagnosis. This represents the secondary diagnosis, with or without substance abuse. And one of the unexpected findings is that people with schizophrenia had the lowest overall rate of violence, both the first 20 weeks into the year. This is, I think, the annual rate. So that you can see overall 8%, but again, in every one of the diagnostic categories, if you have substance abuse, it's 2 to 3 times more likely. So when we say all serious mental illness and look at those charts, even when you break it down, substance abuse, co-occurring substance use disorders are by and large, now this by definition has a substance abuse, so that's an empty cell. You see the same pattern, regardless of the type of disability, the type of diagnosis. Schizophrenia, in some studies people have posited that schizophrenia is more associated with violence. If you look at those studies, go back to my first slide, almost every one of those is violent crime, and almost every one of those studies where schizophrenia is higher, they took a forensic population, they took convicted homicide offenders, they took a group of people who already had been convicted and said, what percentage have diagnosable schizophrenia? It comes out higher. Well, I would argue that that's an inappropriate way to answer the question, because if people with schizophrenia are differentially identified, differentially prosecuted, differentially sentenced, differentially incarcerated, then there's going to be a different proportion in those N groups who are in forensic facilities, who are in maximum security prisons or long-term prisons, than when you take a group of people who have schizophrenia and track them prospectively. And that's what we did here. So in terms of relationship to violence, in our group, schizophrenia made them much less likely than depression, bipolar, and other psychotic. One of the cities we studied was Pittsburgh. And one of the things that people kept saying was, well, how do people with serious mental disorder compare with the general population? And of course, the study just had 1,000 people who were hospitalized and released. So the MacArthur Foundation said, we'll give you some extra money. And in Pittsburgh, we did something that I thought was really cool. We took the study group and we looked at the census tract that they were released to, and we took a random sample of people in the same census tracts so that we had a community sample where we were controlling for neighborhood effects. Because when you look at the data, neighborhood effects, because of poverty and a whole bunch of other things, have a huge impact on rates of violence. So we took people who came out of Western Psychiatric Institute and Hospital and the communities that they went to, and we then got people that we matched with them and tracked them. And the data in this slide is from that. It looks at a community sample and it looks at a patient sample. And what percentage in a given year had a reported violent incident. The community, it was 17.5%, and the patients in Pittsburgh were 31.5%. But that totally masks what the important finding from this bar graph is. The important finding is that if you, based on a MAST and a DAS score in terms of substance use, and if you look at people in the community that didn't score in the high range, and you take the patients who didn't score in the high range, they're practically the same. 3% and 5%. It's not statistically different. That when you take people, their neighbors who didn't have substance abuse symptoms based on the MAST and the DAS, and the patients who didn't were practically the same. But then introduce a positive MAST or DAS score. In the community, just like with the patients, it's 3.5 times higher if, in fact, a general population, someone living in the same neighborhoods, has these symptoms, they're going to be more violent. But it's only about 3.5 times here. With the patients, when you get a MAST and DAS, it goes up to 22%. That persons who have been treated for serious mental illness, who have a diagnosis, when they also have a high MAST DAS score, they go twice as high as the community does.
Okay, for the non-clinicians in the room, can you tell us what MAST and DAS is?
Michigan alcohol screening test, and DAS, I think, is the drug assessed screening test, right? Is that right? And they're, I haven't used them in a long time. How many items? They're like 15 or 20 items. They're very brief. They take 5 minutes, and there's a series of questions. And if you score past the cut points, then you have indications of a substance use disorder. It's not a clinical diagnosis, but it's a way of getting an approximation of people that if they had a full-scale clinical workup, they would show up as having alcohol abuse problems or drug use, substance use problems. So it's just it's a measure. I'm glad you asked. Just anybody else, as I'm going along here, and you want to stop with questions, feel free.
I have a question about the last slide, but what is schizoaffective disorder in your experience?
It would be other psychosis. So the answer is whether a person has a serious mental illness or not, if they have an alcohol or substance use symptoms, they're more likely to be violent. And again, anybody that does criminal justice research, criminological research, that shows up all the time in terms of people that are more likely to get arrested, more likely to be involved in crime. So that, but the influence with persons with mental illness is it's much more substantial. Okay, I think I've got 2 more slides looking at other factors that people always are interested in. What's missing from the top of this slide, for the purposes of the recording and for the people who you have there, it's whether or not people had delusions prior to their hospitalization. So on this column is, did they have any delusions? Yes or no? And this is the threat control override for those people that do delusions research. It's a set of 5 specific questions about people's perceived threat and their people planting ideas in their head. What override? It's a specific subset of delusion questions. that some other studies have found are related to violence. We did not find any relationship between whether or not the person reported delusions in either the people actually had slightly higher percentage. It's not statistically significant, and this is just statistically significant. But basically, there's no strong relationship or any relationship between whether people reported a delusion. And if you look at the threat control override, it's the opposite direction. The people who said no, they didn't, actually had higher rates. So our conclusion from these data is there was no relationship between whether people reported a delusion and whether they were violent. Now, what goes with delusions? Hallucinations. What about hallucinations, you ask? Here we have three categories. We have whether they had any hallucinations, whether they had command hallucinations, whether they had command hallucinations to be violent. And again, the first 20 weeks and 1 year. What you see, any hallucination, absolutely no relationship. Whether the ones that had them had the same percentage of people who were violent in the 20-week and the first year. When you look at command hallucinations generally, no relationship. The numbers are practically the same. The one thing you see, if they had a command hallucination that specifically was commanding to be violent, then you see a moderate difference. It's statistically significant. This is at the 0.05 for those who care, and this is the 0.001. And you see a substantial difference in the first 20 weeks, and particularly over 1 year. So, and I turn this over to the clinicians in the group, but one of the common ideas in terms of, well, who should we pay attention to? Who's a higher, let's see now, who's more likely, I won't use risk or dangerousness, who's more likely to be dangerous? The delusions and hallucinations and, say, command hallucinations, that's what you see people talking about all the time. There's actually not, certainly in our data set, and if you look at the research, there's not that much as it relates to specifically to violence. And it may be because very rarely when people do these, do they distinguish between general command hallucinations and specific hallucinations where command to violence. So, what's the take-home message? Oh, wait a second. One more thing before we do the take-home message. This is going to what David was talking about this morning in terms of criminogenic. And this is getting out of the clinical realm and looking at the criminogenic, or criminal justice, or criminological if you prefer. And we looked at the frequency of prior arrest based on self-reports, the official arrest for crimes against person and crimes against property. And what you see there, which is exactly what you would expect. If you've ever looked at any criminological research, if you ever looked at what's related to violence, what's related to crime, what's related to arrest, in any population of persons with mental illness that I've ever seen published, whether they were state hospital patients, general hospital, outpatient, any group of people who were identified as mentally ill, and then they were tracked in the community to see who was arrested and who was assaulted. The variables that always come out are number of prior arrests, number of prior violent arrests. It's the same measures that come out in the general population. The clinical factors hardly ever have any predictive value. And what you see here is that the people who had more prior arrests had substantially more higher percentage, they had more violence. So more prior arrest, more subsequent arrest. And whether you look at crime against person or crimes against property, same thing. People who report them have higher rates of violence. So, the take-home message, it's all about co-occurring substance use disorders. Diagnosis isn't really that important. Hallucinations, delusions, aren't terribly useful except very specific command hallucinations to violence. And the people most likely to be rearrested, most likely to be violent, arrested for violent crime, are people who have more of it in their prior behavior before they came in. And if you look at the a lot of the presentation that David did in the plenary this morning, when he was talking about the criminogenic factors and how to sort people into the different, I hate to use it with buckets and bins, I hate that, categories and groups. You don't put people in buckets. But when you put them in different categories, that the substance use disorders are a major discriminating point, and they really do raise the question, the attention factor. Those are the people that every study, these data that I'm presenting here, and if you look at anything else, that's where you really need to pay attention. And I guess that's it. That's the.
For the people who were returning from the hospital, was there any categories for where they lived or the type of place they lived? Family, alone, in a group home?
The question is, when people were released to the community, did we look at the living situations in terms of the family, SRO, were they homeless? No, we didn't. I mean, it's in the data set, but we didn't analyze it to see. We just looked at where the targets were, and obviously, if they weren't living with a family, then that wasn't a possibility for the violence, but still 51% were. Most of the people did go back to some type of family or independent living situation.
You talked about substance abuse or substance disorder being a primary diagnosis with the presence of mental illness. How does that compare to just substance abuse with no mental health issues?
We don't have any data on that. That all of the people in this study, if substance abuse was a primary, secondary was mental illness, so everybody in this study had mental illness mixed in if there was any. I'm trying to think. I don't know even the drug court literature doesn't have that. It doesn't. It looks at people that graduate or don't graduate or stay in treatment. I'm not familiar with anything that took just substance abuse and looked at these same variables. Is there anybody here who has any numbers or can think of a study? I'm not familiar. I always come at it from the other side. But I haven't seen anything that focused on specifically the substance use by itself.
On that topic too, I was wondering, were they all indicating that they were engaging in the violent activity whenever they were under the influence of a substance, or did they just have a substance abuse diagnosis?
They either scored high on the master DASC or they had a diagnosis. At one point, we did try and see how close alcohol use had been to the incident, and we just couldn't. It was too refined a question. And we did the data weren't good enough because we had it in 10-week blocks. So we say, in the last 10 weeks, have you done this, but we couldn't tell whether the violence occurred at day 2 and the alcohol. And we asked them about the illegal drug use and stuff, but that could have occurred at week 10. And we didn't have a chronological event, so we couldn't sort that out.
Of your population, how many were actually engaged in treatment in the community, or mental health treatment?
Almost all of them got some initial contact, but one of the things we did look at was trying the intensity of treatment and whether that was related to violence. And I haven't looked at the data in a while, but I think that if they had had in a 10-week period 7 or more, is the number that sticks in my mind, 7 or more treatment contacts, they were less likely to be violent than if they had 0 to 6. So if they had 1 or 2 or 3, that didn't seem to be related. But if there was an intensity of service in the 10-week time period, and the number that sticks in my mind was 7 or more, that there was a reduction in violence. But part of the problem is, what's the cause and what's the effect? They may be in treatment because they're not violent and they don't get arrested. So the fact that they don't get arrested is related to how much treatment they're getting. And it's sometimes hard to sort out what's causative.
Were any of them on court-ordered treatment?
We didn't record that. At that point, when these data were collected in the mid to late 90s, assisted outpatient treatment or involuntary outpatient commitment was very uncommon at that point. It really hadn't taken over. And in the cities, Pittsburgh wasn't used, Pennsylvania, Kansas, and Massachusetts really at that point weren't using it at all. So that wasn't an option. And they were all civil, most were civil patients. They weren't forensic patients, so that there wasn't any court, mandated court supervision when they left the facility.
Did
just curious if you have the numbers based on gender.
We do, but they're not in my head. There wasn't a big difference between men and women that we did look at, and in all of the multivariate runs we did, we put gender in all of them, and it never comes out. That the factors are the same for the men and women, and the rates weren't significantly different. I just can't remember the exact numbers, but there really wasn't any significant gender differences on much of anything, either the prevalence, the type, the target. My recollection is the women were somewhat less likely to have stranger violence. Most of their violence was, in fact, family and friend and acquaintance.
So in terms of that model over there, what kind of interventions does this suggest that we might focus on if we're wanting to prevent violence?
Good question. Let's look at this together, because I haven't factored that in. So everybody in our group is these dark blue categories. They all have serious mental illness. We had a prevalence rate of co-occurring disorder around 55-60%, as I recall. So more than half had a substance use disorder. But we didn't measure them on criminogenic risk as such. We didn't do a risk of, we were looking at whether they would be violent, whereas, as David said this morning, they're looking at whether they'll be rearrested and whether they'll be violated. I think those were the two criteria that he used. So it doesn't quite fit, because this is criminogenic risk, and this is serious mental illness, medium, high, medium, high, medium, high. I don't know. What are your thoughts as you look at this? Do you see them fitting any place particular?
Well, I guess you'd be pulling out for some kind of special intervention the ones who are both mentally ill and co-occurring, using substances, that you'd probably pay specific attention to ones who are experiencing hallucinations that command them to be violent, but I wonder what you'd be doing with them.
Well, in group 4, we have medium to high substance abuse and medium to high mental health, and it clearly would fall in that group, but we didn't have criminal risk. In group 6, that would not be the case. So the two groups that this study population would fall into would be group 8 and group 4, but we don't have a measure for that, so that they would be in one of either 4 or 8. I don't have the rest of the grid in terms of that he had this morning, in terms of what were the interventions.
But wouldn't your other mental disorders not be SMI?
I couldn't hear that.
The other mental disorder category would not be SMI.
No, it'd be personality disorder primarily. That was in our study, that was primarily.
You don't know whether that falls into criminogenic kind of factors versus mental illness. So it's
as a total non-clinician, and as someone that at times isn't enthused about the DSM-4R, or I haven't seen the DSM-5, as it relates to people who have criminal justice involvement, I've always felt that antisocial personality disorder and personality disorder generally in this population doesn't tell people very much. Because as I said in passing, somewhat facetiously, but I actually believe it, if you see the rap sheet and you see a lot of history of violence, that in the absence of anything else, they get that diagnosis, and it's almost a criminogenic diagnosis. Now, you're a clinician. Do you agree with that?
No.
Okay, tell me more.
When I worked in the prison system, the folks...
Speak loudly so people can hear.
When I worked in the prison system, what I noticed is that the folks with a paranoid flavor to their presentation, whether they had a paranoid personality or maybe it was some form of schizophrenia or whatever, those individuals engaged in violence more often and had that kind of
While they were
record.
Incarcerated or in the community before?
Both.
Uh-huh.
In the jail themselves, they were constantly being locked up for like cussing people out and hurting them or hitting them, or in the community they had committed violence.
One of the other things, a footnote I would add to that observation that you really got to be careful about is when studies of persons with mental illness have looked at who is assaultive in either forensic or regular hospital and in the community, there's no relationship. People who are assaultive in hospital are no more likely to be assaultive in the community than those that don't. They're two different worlds. They're two different situations. They're two different sets of circumstances. And there's no, it's not a good indicator. It's not a good predictor of who will be violent in the community. I haven't seen those same studies done of people that get tickets and special housing in the jail. But I mean, typically, you know this. Violence is dynamic. It's situational in the different worlds. Now, someone else disagreed with my personality statement. So tell me more.
My experience is less in the criminal justice and more in the mental health. And so, in my experience, the personality disorders are more of a danger to themselves than they are to other people.
Well, that's a good point. None of these data look at danger to self, that suicidality. A whole other research area. We didn't look at that, and those. It's a whole different set of factors, and it's interesting because this framework, which I think is incredibly thoughtful and complex at the same time, says nothing about people who are a danger to themselves. It doesn't look at that. It's not considered. The question is, are they going to get rearrested? Are they going to get violated? That's what it really focuses on. So that's a whole other ball of wax that we need another presenter and another set of data to do justice to.
What I kind of find also interesting is if you go according to the federal definition of violence, and that applies to the individuals that how you define violence would not be able to participate in a mental health court because of the level of violence. The risk is too high to the community. So that level, that group 8, according to this, would not apply, would not get access to a mental health court.
The only mental health courts in the United States that the federal definition of violence would relate to are the small number of mental health courts who get Justice Mental Health Collaboration money. Because there's no other federal money that funds them, so they're not bound by any federal definition of violence. You can have anybody in your court that the judge, the prosecutor, and the public defender, usually it's a judge and a prosecutor, are willing to take, and that the community providers are willing to provide treatment to. So
that is true. However, you have to be careful. If you do bring somebody into your court, and if they have a significant violence, and your study really supports that their risk to the community is significant, and the violence does occur in the community, the potential impact of the media and all of that is going to shut your court down, potentially.
Potentially, but the mental health court, this is kind of getting sidetracked here, but mental health court, the data that I've seen is the mental health courts that have the biggest savings to the community in terms of jail days and recidivism are those that are most willing to take felonies and look at the felonies on a case-by-case basis and just don't have a blanket. I don't know, have any of you, I think it's public, seen drafts of the new Justice Mental Health Collaboration? They changed the definition of violence, and it's going to be now what I just said in some language, but basically that people, except for a couple exceptions like sexual assault and a couple others, that it will be defined as it can be looked at on a, I think it says case-by-case basis. So it's going to be, if in fact the legislation passes and there's an appropriation for it, it'll be different and be much more open and much leave it to the local community, the prosecutor and the judge and the public defender, to come up with something that their community is willing to work with. So I think there'll be a lot more latitude if this bill passes.
I'm just going to give the other side of that argument. The other side of that argument is if that individual is going to be in your community and isn't going to go to prison, is going to be out, we would much rather in our community have them in our mental health court with all the services around them and the intense supervision knowing, rather than just a probation officer having to be responsible for that person, out on their own. So the other side of that is they're there. Why not put them in the best treatment you've got for them?
Speak louder, please.
We have a mental health court. We've had one of our participants successful murdered a baby. There was no linking. We had no media problems.
Was it a man or a woman?
Fear.
Was it a man or a woman that was?
Man. Yep, shaken baby. So I think that's survivable. Because I think that's a lot of times a local problem. What's the relationship to media? How good are the courts? And as a supervisor of mental health courts, I'm fearful that one of my folks is going to go kill someone, but I now have come to believe that is not necessarily going to shut us down.
Well, I think that's a good point, and again, we're kind of swaying a little bit, but I think these are interesting ideas that preparing for the almost inevitable bad case. It's going to happen. No matter how good a job everybody's doing, it's going to happen. And are you prepared? Have you had the media do a positive story? Have they been exposed to your court? Do they already know about all the good things? Do you have some data on how many people you've enrolled in the court, how many graduates, what the low recidivism rate is, and do you have a couple of cases that you've already written up? And if the person happens to be an articulate person who can get in front of a camera or a community group, and you have them already lined up and you already have the write-ups, so when something hits that's negative, in fact, when you have an adverse event, if you've done some preparation, you're way ahead of the game, and I think you're much more survivable. And the other thing is, if you're only in your first year, that can be tough. But if you have a 2, 3, 4 year track record, I think that it's very survivable, even when a bad event happens, which is almost at some time going to be inevitable.
I think that really depends on where your community is located, and it depends on the racial breakdown between the population and the newspaper. If you have a newspaper that is hostile to your local population, or media that's hostile to your local population because there are racial disparities and there's racism operating, then that will shut you down. It will be a significant problem if the population you're dealing with is people of color and you have a relatively racist press. You're going to have a real problem if that happens.
That certainly is a bigger challenge, but I think one of the things that you tell me, but I think can help if when you first get these grants or you first establish your court, but especially if you get a grant, and everybody is here at this meeting because you got a BJA grant, of leveraging the announcement of the money in terms of engaging them and saying, look what our community is going to get. We're special. There's, 5% of all U.S. There's 3,500 counties in the United States, and I think roughly 250 of them have gotten a BJA grant. So yeah, you're an elite group, and to kind of use that as leverage in terms of what you're doing, how you're doing it, who's going to be treated, and trying to get the press to personalize it, to let them meet a Hispanic woman who is in trouble, an African-American male, a Native American, depending on where you are and what the bias is, what the racial bias is and the disparity may be, and try and get someone to link to a person or two that's in your program. And really, there are likable people in these programs. Some of them are tough, and some of them don't communicate well. But when you look at all the people in any given time that are on your rolls, you've got some pretty likable people, some pretty interesting people. And if somehow or other you can hook the press to do something about them, particularly when you first get funded, but then you don't have the thing, I think that helps assuage when you get those other challenges.
Could you go back to the slide where you were talking about violence and specifically guns and what percentage people threatened with guns?
So just under a third had, and again, that's got a whole lot of stuff because like the example I gave was a real one. I mean, someone picked up a lamp and was shaking it at the person. They got coded as threatening with a weapon. Sometimes they go and they pick up a knife off the kitchen sink, and they're not really going to do it, but it counted as threatening with a weapon. And then there were some, and I don't have the narratives on when guns were used, but there were 67 events, which is 11%, involved a gun in the room. If the gun, again, the decisions you have to make when you're doing a study, if the gun was in the room and they threatened to use it, we said that they threatened with a weapon. If the gun was in another room and they didn't go in the other room, then it wasn't coded as using a gun.
Not that you can't die by knife, but it does have implications of, gun and suicide and access to weapons shortly after discharge from a hospital is something that needs to probably be addressed in treatment and in other areas.
No one was killed by a weapon. There were no lethal violence. You have a question? Or comment?
I deal with people who have been committed to state hospitals either through the forensic or civil system. And in my experience, the people that I'm most concerned about are those people that have been deemed NGI who have already killed maybe multiple people, who are coming back to be placed in the community, versus your typical schizophrenic, bipolar, who acts out in the community, ends up being Baker acted and brought to the CSU.
Oh, you're from Florida, huh?
I'm sorry?
You're from Florida.
I certainly I am much more concerned about those people who are on conditional release, who have murders and those types of violent crimes, versus what it seems like we've been talking about here. Because and the community has no idea that when somebody has been put on a conditional release, they're coming to your neighborhood at some point. So those are the kinds of things that kind of...
There's not a single research study that I'm aware of that's taken a group of not guilty by reason of insanity, who are usually long-term forensic patients, 10, 12, 15 years, and then looked at their level of violence in the community and the factors related to violence. Part of it is, I think there's some of the, and I think Florida's pretty good at it, but in most states, that's as intense a level of supervision as most people get, because there's such a chance of bad press and there's so much concern that there's actually, I think, a relatively low prevalence rate of serious violence among conditionally released insanity defense releasees, because it's usually they're so concerned with the kinds of things you talked about that they get pretty intensive supervision.
For initially.
Yes.
But as they do better and better, then they're pretty much placed in independent housing.
Yes.
Yeah.
Yes. Well, I'll take one last question, because I think we're supposed to be going to lunch at this point. So you get.
So with regard to your substance abuse diagnoses, were there any predominant kind of alcohol, marijuana, drugs that you found?
No, we looked at cocaine as a specific thing, and it didn't show up any differently than anything else. But again, it wasn't a very refined measure. And when we did the study, meth was not a big issue at that point in the communities we were, so that wasn't anything. And we didn't really look at marijuana.
Alcohol, I think.
Alcohol.
Yeah.
Yes.
Alcohol, definitely.
Yeah.
Yeah.
Well, thank you all. Have a good lunch. I guess.